Welcome to this episode of ASNC's interview series. My name is Nishant Shah, and I'm an associate professor of medicine at the Brown University Alpert Medical School. And I'm delighted to be joined by Dr. Filipe Moura, who I would like to ask to introduce himself.
Thank you, Nishant. So I'm Dr. Filipe Moura, and I'm an assistant professor of medicine and cardiology at Yale.
So thanks, Filipe. Today, we're going to be talking about where PET is winning, its expanding role in metabolic applications and opportunities for growth. To help us out with this topic, we're fortunate to have with us Dr. Jamie Bourque, who is ASNC's president-elect and author on a number of influential articles on this topic, including the recent multi-society PET-CT and SPECT-CT imaging for the evaluation of cardiovascular infection in the multimodality context. Dr. Bourque, Jamie, would you please introduce yourself?
Sure. And Nishant and Filipe, thank you for having me today. I'm delighted to be here and talk with you all. I'm a professor of medicine and radiology at the University of Virginia.
Thank you so much, Jamie, for joining us and giving us your wisdom today. So let's get right into the first question. This is really about quantitative PET and myocardial flow reserve. As you know, cardiac PET-CT perfusion imaging now allows us to integrate several things, including myocardial perfusion, LV systolic function, coronary artery calcification, and absolute myocardial blood flow, leading to a dramatic shift in our ability to characterize and understand coronary artery disease. Jamie, how do you believe these advances have impacted diagnosis, risk stratification, and clinical management of patients?
Thanks, Nishant. I think that our advances in PET perfusion imaging and our increasing use of this modality are going to be key for moving our field of nuclear cardiology forward. I think that PET CT perfusion imaging has superior accuracy. And as you had mentioned, there are a variety of important aspects that we get when we do a PET perfusion imaging study. With the tracers having superior spatial resolution and other favorable characteristics, we're able to better identify the extent and presence of perfusion defects. We can get the left ventricular ejection fraction reserve, a true stress ejection fraction. And then, as you mentioned, the ability to assess absolute myocardial blood flow can help us not only with assessing stress flow, but also the myocardial flow reserve, which gives us a wealth of information on both for diagnostic value as well as prognostic purposes. So we're really excited to have PET and with the expanded ability of recent tracers now allowing us to do exercise, I think it's an exciting time.
And that's great. I agree as well. In addition to it being an exciting time, we know that these studies with incorporation of all of these different elements are getting more complicated. How should our reporting of these more sort of nuanced and complicated findings evolve to make sure that referring clinicians can still understand our final interpretations relative to some of the simpler reporting that we did maybe with SPECT MPI?
It's an excellent question, Nishant. I think that, and I feel very passionate about reporting, so this is an area right up my alley. I think that it is going to be very important as we have all of these different components of the test that we provide an integrated conclusion for providers that synthesizes the multiple aspects of the study that are performed. And I think this is one area where we can potentially take a page out of the CT playbook with CADS-RADS, where they've given a very structured, defined way of providing results and sort of very specific recommendations, potentially also about what you might do with those results. I think that is an area that we probably need to look at developing. And so I think there are a lot of ways that we can improve our, as we increase our use of PET and we increase our use of the absolute flow, that we can really refine our response back to referring clinicians.
Well, thank you, Jamie. I think It was really insightful, particularly about the reporting. I'm looking forward to see how that develops and being part of that. I wanted to move on with the next question, a little bit more about the evolution of PET in cardiovascular imaging as a whole. So cardiac PET has fairly recently expanded from assessment of myocardial perfusion, like we talked about, and viability into assessment of cardiac inflammation, cardiac devices, infection, and amyloidosis, and even cardiac metabolism, which you started alluding to in the beginning of your response earlier. In your opinion, Jamie, what are the key breakthroughs here that allowed this incredible expansion?
So, in addition to the exciting areas in perfusion with PET, I think the ability for tracers to assess metabolism is really important. And so it's exciting that not only can we look at viability, which was an area that PET has done for a long time, but as you mentioned, there's also the ability to assess inflammation and infection. There's been a fair amount of use of inflammation imaging with sarcoidosis with PET, and I think a lot of excitement for assessment of active disease. And I think that will continue to progress and refine. But particularly exciting for those of us in the US who have not been able to have studies reimbursed for doing infection imaging, we now have the ability to perform these studies, get reimbursed for them. And we now have guidelines, the ESC guidelines, the refined Duke criteria for infective endocarditis, and then our ASNC imaging indications multi-societal consensus statement that all provide very specific recommendations on when we can use this imaging in the assessment of infection. And really, FDG PET-CT and to a lesser to a good extent as well, radio-labeled leukocyte scintigraphy, SPECT-CT, can be used to assess for infection in patients who have any sort of equivocal findings, in patients who have a high clinical suspicion where nothing is seen by echocardiography, to assess fever of unknown origin. There are a ton of clinical indications where this can be used. And I think one of the things that was most exciting about our consensus statement is that we actually had involvement of some of these societies beyond imaging. So we had ACC, we had AHA, we had 2 cardiothoracic surgery societies, and then we had the IDSA. We had our infectious disease doctors who were providing all of the clinical indications that they found helpful. So I think there's going to be a lot of increased use of this modality, and I think it's an exciting time. And then I don't want to go on forever here, but also just the ability for us to assess amyloidosis. I know we're going to talk about that in a second, so I'll leave that. But then also vasculitis is a really exciting area. And there are multiple novel tracers, inflammation tracers, and infection tracers sort of on the horizon. So again, very exciting time.
Well, thanks, Jamie. That actually is a great segue to our next question, which actually talks about some of the novel cardiac PET tracers that are coming out. So, flurpiridaz, sodium fluoride, FAPI, florbetapir, evuzamotide, just to name a few. A lot of these are under active clinical investigation right now and hold tremendous promise to even further expand the utility of cardiac PET for coronary artery disease, as you mentioned, amyloidosis, and cardiac metabolism. Amongst all of these tracers, what are you most excited about with respect to what might have clinical impact over the next decade or so?
So in the immediate term, I'm very excited about the opportunity with flurpiridaz coming on the market. I think that this is going to be a perfusion tracer because it can be given or provided in unit dosing because of its longer half-life. We're going to be able to expand the use of cardiac PET perfusion imaging to geographic regions and centers where this was not possible before. So I think that's very exciting. the favorable flow characteristics with the perfusion tracer, as well as the ability for the first time to at least easily do exercise stress with cardiac PET is going to be very exciting. So right now, immediately, we're going to get some benefits there. And then I think that I'm particularly excited about some of the tracers that are being used in cardiac amyloidosis. In particular, I-124 evusamotide, and to a certain extent, some of the other tracers as well that are pan-amyloid agents. So they're able to assess AL non-invasively, which currently requires, as you all know, doing an invasive biopsy. So our ability to assess both AL and ATTR amyloidosis. And then going back to evusamotide, the sort of high sensitivity, good specificity, comparable, if not even a little better kind of performance compared with florbetapir for the assessment of amyloid cardiomyopathy. And then I think with the PET amyloid tracers, the improved ability to do quantitation, which will then allow us to do repeat serial imaging to assess for disease progression as well as response to therapy, I think is going to be really important and helpful.
Great. Thanks so much. Filipe, the next question.
Yeah. Thanks, Jamie. Always very insightful. I'm going to, in the midst of this advance in the biomolecular aspect of imaging, as you know, there's been rapid uptake of AI, artificial intelligence, in many areas of medicine, specifically in imaging. We already see it impacting cardiac PET CT and nuclear cardiology in general. I think some of us have been using application of this in image quality improvement and other aspects. But I wanted to hear from you, Jamie. What are some of the AI applications that you specifically are most excited about?
I think there's going to be an enormous amount of improvement and in our use of artificial intelligence over the next decade. I think there's some very exciting areas that are already under development or even can be used now. Attenuation correction, motion correction, ability to do calcium scoring and without doing the full formal imaging that's currently required to do our formal calcium scoring. So I think those are all areas. I think that there'll be some interesting aspects for reporting with our large language model capability. So a lot of very exciting areas. And then I think the other interesting aspect to AI is going to be the importance of developing payment structures so that we can appropriately bill and get paid for these tools. We definitely want to make sure that that we're retaining the ability to have readers who are doing a ton of work be paid appropriately as well. So there's some kind of areas to fine tune there. There's an enormous amount of work in consortia with industries in terms of training sets and sort of code development of important areas. And then I think it's very important for us to make sure that concepts of ethics and justice are followed as well. So I'm very excited about AI in this field, and I think it's going to provide enormous strides. And I think there's some very interesting work that will need to go alongside it.
Thanks so much, Jamie. And obviously, we want to close out by just sort of saying thank you for your leadership in nuclear cardiology. We're excited for you as our president-elect and our soon-to-be president in 2026. Obviously, you've highlighted today quite a bit of work that we've already done that's already exciting, but I think we've also highlighted, what's to come in the next decade that's almost equally, if not more exciting than what we've already seen. So on behalf of Filipe and myself, I just wanted to say thank you so much for taking the time today to speak with us and to really kind of highlight the exciting things to come. Really appreciate it.
My pleasure. Thank you very much.
Thanks, Jamie.